everybody. My name's Carl Harper. I'm an assistant professor of orthopedics at Harvard Med School, and I'm the director of the Hand and Upper Extremity Microvascular Fellowship. And I'm very excited to talk to you today about the stiff elbow. And we are going to be taking a very holistic approach to this, working on everything from prevention to ultimate treatment. So with that said, elbow anatomy as it begins is crucial to understanding and talking about elbow stiffness itself. And what we have to understand is that while this is a highly constrained joint, I mean, there's not a lot of degrees of freedom in it, it is in and of itself a relatively unstable joint from an osseous perspective. And the three articulations that we sort of all know exists, that being the ulnohumeral radiocapitellar and the proximal radial ulnar, are stabilized themselves by a vast complex of ligamentous structures. And when one begins to think about the stiff elbow, it is these ligaments that play a major role in said stiffness. And what's fascinating about the elbow in particular, more than really any other spot in the body, with the exception of maybe the hip, is that these ligaments not only themselves contract, but rather also can ossify. And why that happens is a little bit unique, and we'll delve into that a bit later. On the lateral aspect of the elbow, you've got your annular ligament that stabilizes the radial head, and then you've got both your radial collateral ligament attaching the humerus to the radius, as well as the lateral ulnar collateral ligament, or the LUCL. And it is the LUCL in particular that is problematic on the lateral aspect of the elbow. Medially, you've got your medial collateral ligament complex, which really forms a triangle with the anterior band of the MUCL, or the medial ulnar collateral ligament, providing the tremendous amount of stability to the elbow, and the posterior band, as we'll discuss later, really being the culprit for limitations in elbow flexion. Said differently, if you have a stiff elbow that lacks elbow flexion, one has to consider that posterior band of the MUCL. And then anteriorly and posteriorly, you have your big, thick capsuligamentous structure, which not only confers a tremendous amount of stability, but also represents or gives you the potential to have a significant amount of stiffness post-op. So in terms of the approaches, no lecture would be complete without discussion, at least orthopedic lecture would be complete without discussion of the critical neurovascular structures that exist. And so as one begins to think about the stiff elbow and preventing stiffness or subsequently treating the stiffness, the lateral approach to the elbow that many view as the workhorse. And in point of fact, there's quite a bit of research out there on how to release the elbow almost exclusively from the lateral side. If one is going to do that, one has to be aware of the radial nerve. And so that comes into play, 6 to 8 centimeters proximal to the lateral aspect of the lateral epicondyle, and then becomes much more prevalent just distal, as you can see here in that middle picture, just distal to the radial head proper. The medial approach to the elbow, and we'll discuss the Hotchkiss over the top approach in a couple of slides. The ulnar nerve, and that's somewhat obvious, is the major neurovascular structure in the way, and identifying particularly the ulnar nerve when one begins to address elbow stiffness is crucial. So what is a functional range of motion? I think that's kind of tricky, and people often gloss over this important fact. We talk about the stiff elbow, and implicit in that statement is that it confers, or a degree of disability is conferred due to the stiffness. Well, how do we know? And so Bernie Morey, who is from Mayo in Minnesota, did a study among several in 1991. It was published in JVJS. It's very famous. Many of you have read it. And whereby he actually splinted farmers in certain degrees of flexion extension and surveyed them, evaluating what they could and could not do. Said differently, how functional were you with such and such a range of motion restriction? And what he came up with is a 100-degree arc of flexion extension and a 50-degree arc of pronous supination. That being said differently, from 30 degrees, or lacking 30 degrees of terminal extension, to 130 degrees of flexion was considered a functional elbow range of motion. And again, 50 degrees of pronation supination, that being 25 degrees on each side of neutral, resulted in a relatively functional human being. So that's where those numbers come from. It's actually one very specific study. Now, that being said, terminal flexion, or being able to flex the elbow, is much more important than elbow extension, because being able to get a fork or some form of eating implement to your mouth is very important. We all love to eat, and being able to feed yourself, being able to wash your face, being able to wash your hair, and in general engage with your environment from a hygiene perspective is very important. And elbow flexion is what confers that. A lack or sort of a deficit in elbow extension, while it can be problematic for certain occupations, most of the time we can accommodate to this relatively well with positioning the shoulder or moving the body. And when one thinks about elbow stiffness, you really want to avoid trading elbow flexion for elbow extension. All right, so there is a classification system, both when it comes to HO, which we'll talk about in the next couple of slides, as well as just purely elbow stiffness classification according to the Mori classification, that being intrinsic versus extrinsic. And that is, somewhat intuitive in the sense that things inside the joint can confer stiffness, and things outside the joint, including the capsule, can confer stiffness. But the stark reality is almost nobody utilizes this Mori classification in isolation. It's nice to talk about in research, but in general, almost all pathology is mixed, meaning there is a component of the stiffness that is due to intra-articular issues, i.e. heterotopic ossification or impinging osteophytes. There's almost always a component of the stiffness that is extrinsic, said differently, the capsule or muscle contractures. So almost everything is mixed, but you need to think about it algorithmically. And the four key questions as it pertains to elbow stiffness are: one, why is the elbow stiff? Two, where is the pathology located? Three, is the joint unstable? And four, and I alluded to this earlier, what's going on with the ulnar nerve? Is the ulnar nerve normal? Because that will be tremendously important when one begins to think about contracture release and the implications or the impact of the ulnar nerve on immediate motion following ankylosis for a long period of time. So in terms of imaging, I know we're going to try to sort of crystallize this down to folks who may be in a sort of resource limited environment. X-rays are really the sine qua non. You cannot really address a stiff elbow without imaging. CT scans or other higher level imaging modalities are nice, but if with a good set of X-rays you still have questions about what's going on, I think you need to pause and slow down, because the stark reality is almost all the time we can get everything we need from sort of orthogonal radiographs. So the first thing we're looking at is, are the fractures healed or not? And for me, fractures being healed is the most important step. I don't begin to address stiff elbows unless fractures are healed, because all you're going to do if you unlock that elbow is going to precipitate or worsen that non-union or pending malunion. So first and foremost, do the radiographs demonstrate a healed fracture? And then secondly, if there's heterotopic ossification, where is it? Is it in the front and the back? And in the next couple of slides, we'll talk about classic locations for this heterotopic ossification or heterotopic bone. It's important to note that while rare, you can have a stiff elbow without the presence of HO. It's not necessary. Doesn't have to be there in order for you to develop a stiff elbow. So don't be shocked if you're looking at X-rays of a distal humerus fracture, for example, that show a healed distal humerus fracture, no heterotopic bone, and yet the patient's clinical exam shows minimal to no motion. That you should actually get yourself lucky. That is indicative of a capsular contracture. In a sort of a more resource available environment, one would consider a CT scan. And I do like a CT scan because it does a really good job at evaluating both the coronoid fossa in the front and the olecranon fossa in the back. Oftentimes there's quite a bit of heterotopic bone there, and one needs to sort of begin to understand where it is, how much is present in order to remove it. So HO itself, heterotopic ossification. The stark reality is, we understand what it is, but why it grows there is still up for debate. This is lamellar bone, so it's incredibly hard, incredibly strong, and it will grow not only sort of adjacent to existing bone, but also through the soft tissues, through muscle, through ligaments. And why that happens is still up for debate. We don't really have a great animal model for this. What we know is incidence. We know it's natural history. So we see about 3% of patients who sustain a simple elbow dislocation have HO, not particularly high. A true elbow fracture dislocation, such as a terrible triad or radial head and ulnar On a humeral dislocation, 20% of those patients. Isolated head injuries will also demonstrate 10% of heterotopic ossification at the level of the elbow. But it's really when you combine a head injury with elbow trauma. Said differently, patient who sustains a high energy injury as a result of a car accident, in which they have a bad distal humerus fracture and also a head injury, those people are going to develop HO at a tremendously high rate. 75+% of the time, you're going to see patients develop HO. Now, that HO is not necessarily symptomatic, but it's present. And this is the Hill-Hastings criteria 1 through 3, evaluating or defining heterotopic ossification. Again, similar to the Mori classification, we don't necessarily utilize this when we talk about things clinically, but it is nice when you begin to write papers or read papers to understand that, for example, a Hill-Hastings 1 in the HO scale is presence of heterotopic bone without functional limitations, and 3 being complete ankylosis of the forearm or elbow, as we saw in the previous slide. That's spanning heterotopic bone, effectively locking the humerus and the ulna together. So common locations, and this is a bit of a sort of a tips and tricks element, or a tips and tricks slide. There are common places that one develops heterotopic bone for certain fractures. For an olecranon fracture, you're going to expect to find HO if it's present at the posterior MCL, and this again would limit elbow flexion. For radial head fractures, you're going to see it about the anterolateral capsule and adjacent to the PRUJ. That makes sense. For terrible triad, so basically radial head with a dislocation, you're going to see it at the anterior and posterior capsule, and that probably speaks to the fact that the tissues that are ossifying are the ones that were themselves traumatized. And lastly, distal humerus fracture. It's essentially the entire capsule, anterior and posterior, plus the brachialis, plus the triceps. So these are the really, really tough ones. In general, like many things in medicine and life, prevention is better. You'd much rather prevent something from happening than treat the consequences of it. And that can be affected through numerous things, including early operative intervention, modifications of your surgical technique, early post-op immobilization, and then there is some element of medical and or prophylaxis utilizing radiation therapy. So speaking of radiation therapy, this received a lot of attention historically, and really it's a derivative or comes from our experience with hip heterotopic ossification, which I'll show you. NSAIDs, or non-steroidal anti-inflammatory medications, the most common of which in the US at least being indomethacin, has also received a lot of attention, and we'll talk about the differences between those two, both in terms of their efficacy as well as cost. In general, radiotherapy is typically delivered within 24 hours post-op or within 72 hours, 24 hours pre-op, I apologize, or 72 hours post-op. And it's usually a single fraction, although there are some people who advocate for multiple fractions. Anti-inflammatories like indomethacin are incredibly cheap and easy to use, but there is some sort of complications that one experiences, both with respect to renal function, if the patient has a renal issue, and or GI upset. And the recommended dose ranges from 75 to 100 milligrams a day for up to 6 weeks. And my preferred algorithm is 3 weeks, but there's, again, minimal data to support 1 versus 3 versus 6 weeks. In terms of radiotherapy's ability to prophylax against surgery, prophylax against heterotopic bone and therefore the need for surgery, what we see here is some relatively good data out there in general. And so the study in the upper right shows 36 elbows treated with radiation therapy in a single fraction with only an 8% recurrence of new heterotopic bone. So pretty good. In terms of discussing when one does it, when one administers it, pre-op versus post-op, and the overall dose, there doesn't really seem to be much of a difference, although there may be some trends in certain papers towards multiple doses post-op. There can certainly be some problems with that, and I'll show you a very, very famous paper in a minute or two that speak to the problems with administering radiation therapy post-op in the setting of an elbow fracture. But in general, we do see some degree of efficacy with radiation therapy. Is it superior to indomethacin? Not quite sure. The head-to-head studies that do this look at HO in the hip. And when one looks at this very famous article from Skulko's group at HSS in New York, we see no difference in the efficacy of HO prevention between NSAIDs and radiation therapy. The big criticism of this article, which was published in Core in 2009, was that there may have been a power issue. You can certainly argue on either side of the fence on that, but in general, most people would agree some form of prophylaxis, NSAIDs versus HO, is a good idea, but choosing one versus the other, it's really hard to pick, with the cost differential being the driver in many health systems. NSAIDs are a fraction of the cost, $20 in this particular study versus almost $900 for radiation therapy. The real question here is, how does it apply, or what are the implications for elbow? And so this randomized controlled trial, which was done in the Carolinas in 2010, or finished in 2010, evaluated the use of radiation therapy to prevent HO in acute elbow fractures. And so what there were two groups, one group receiving no radiation therapy, a second group receiving radiation therapy administered following a distal humerus fracture or elbow fracture dislocation. And this is a very interesting study because it was stopped early. So within the study group, within the radiation therapy group, they were given a 700 centigrade fraction up to 72 hours post-op. And what they found is that in the radiation therapy group, 8 of 9 patients went on to non-union versus a 38% non-union, for an overall non-union rate of 38% versus 4% in the control group. The control group being the group that got no radiation therapy. So they stopped this study. So this is the only one of its kind, but one has to take it seriously in the sense that potentially radiation therapy may not be a good idea, particularly administered following a distal humerus or an elbow fracture dislocation in order to prevent HO. It may not be worth it, said differently. Like many things in orthopedics, treatment for stiff elbow begins with conservative measures. And so splinting, both static progressive, i.e. a jazz splint, or the custom constant load flexion splint, as you can see on your far screen right, have been shown to be efficacious in improving elbow stiffness. The question is, how long do you do it and when do you stop? And so what we see here is this being employed with good success when there is not, or in the absence of, significant heterotopic bone or what one feels to be a bony blockade. So you're not going to be able to overcome a bony blockade through progressive splinting, but everything short of that does respond quite well. Well, how long do you do it? Both the Galinas article in 2000 and the Linden-Hovius article at MGH in 2012 looked at this directly, with the latter article comparing a JAS, or a static progressive, to a dynamic splint. And what we found is that both splints are quite efficacious in improving range of motion, but one sees the majority of improvement in the first 6 months. There's really very little benefit to be gained by continuing to push somebody through a dynamic or a static progressive splinting protocol after 6 months. Most surgeons will, after 6 months, assess the situation, speak to the patient, and if they continue to lack elbow range of motion and have disability, we will then operate. The indications for surgical intervention are as follows. We talked about the Mori 30 to 130 range of motion protocol, or 30 to 130 range of motion definition of normality. Well, in general, if you lack elbow extension of 40 degrees or more, that's an indication for surgical release. Similarly, if you can only flex to 105 degrees, that is an indication for surgery, in addition to the presence of significant HO or large loose bodies. The important thing to note here is that a patient's compliance is essential. It is crucial for success. So if a patient is not cognitively, or from a resource perspective, able to engage with therapy post-op, it is not worth the surgical insult. It's not worth the morbidity of surgery in order to try to achieve better range of motion. So there's all sorts of complicated algorithms that you're going to see online in journal articles. In general, the way I distill it, for myself at least, is you have your imaging, whether it's pre-op x-rays or pre-op x-rays plus CT scan, go where the stiffness is, go where the HO is, go where you know the problem to be, and utilize your approaches in order to affect that. So most of the time, the lateral column approach, or the lateral elbow approach, will be sufficient to achieve significant improvement in elbow range of motion. The problem with the lateral approach, not surprisingly, it's in its name, is it does not provide good medial access. So if you have an elbow that's been stuck in flexion for a hugely sort of prolonged period of time, markedly increasing that flexion past 90 degrees can result in an ulnar nerve neuritis, and one would want to be able to release the ulnar nerve to do so. So the lateral column approach is very, very useful, but does not give you any access to the ulnar nerve, which can have issues, and it doesn't give you any access to the posterior bundle of the MCL. So again, if you've gone laterally and they continue to lack flexion, you're going to have to go medially in order to address the posterior bundle of the MCL, in addition to addressing that ulnar nerve. One sees here the lateral column approach. It does a very nice job at preserving the lateral ulnar collateral ligament and the lateral elbow stabilizers, while still giving you excellent access to the anterior and posterior capsule, as well as the coronoid and a large chunk of the PRUJ. The over-the-top approach, which is the medial approach popularized by Hotchkiss, is indicated for extrinsic contractures, or basically capsular contractures, with MCL contracture, i.e. lack of elbow flexion and or ulnar nerve symptoms. And it's just what you see here, is once the ulnar nerve is identified and carefully protected, you can completely release everything except the anterior bundle of the medial collateral ligament to effect improvement in both elbow flexion and extension. You can also excise the anterior capsular from here very carefully and very safely. Similarly, you can get access to the olecranon tip and the coronoid tip without having to jump over the radial head. So this is a very nice approach that can be used if you continue to have stiffness after your lateral approach. The medial approach, or the approach that we just discussed, the over-the-top approach, gives you great access to the median nerve and the brachial vessels. What you don't see is the lateral structures, and so oftentimes what one has to do in the setting of significant arthrosis and significant stiffness is just that, a combined approach. The reality is sometimes you don't have a choice, and many patients will have already undergone a prior posterior incision. I would not advocate for putting 3 incisions on somebody, going medial, posterior, and lateral, but rather one big posterior incision with large skin flaps raised radially and ulnarly to give you exposure. Additionally, this posterior approach also gives you access to the proximal radial ulnar joint from the posterior aspect, from the back. And so if you have PRUJ ankylosis, you can access it through there. Arthroscopic release, particularly in a resource-limited situation, does not have much of a role, so I spent one slide on it. There are certain people, Sean O'Driscoll and the Mayo Group in particular, that come to mind that are absolute masters of arthroscopic release. I would not advocate for this for the regular practicing orthopedic surgeon or upper extremity surgeon. I would really leave this to those that are expert at it. Specifically, published contraindications of arthroscopic release include heterotopic ossification, a severe contracture, and a prior ulnar nerve transposition, or really only any ulnar nerve work. So it can be very effective in the right hands, but certainly would not be employed for a large degree of ankylosis or anything significant. In terms of hinged external fixation, people talk about this a lot. That being said, the likelihood of one destabilizing the elbow following a contracture release is extremely low. So this is probably, more of a historical discussion than an actual operational discussion. One can employ both a hinged external fixator or the Skeletal Dynamics IJS on the right, which is the only internal fixator that's been shown to allow or confer stability while being contained within the skin. So when I've got this, more in the setting of trauma, use the IJS. But I have not yet encountered a situation where I went from a stiff elbow to a grossly unstable elbow and needed to employ hinge fixation, although this would be your treatment of choice in that setting. In terms of postoperative management, we talked about the use of radiation therapy, whether to use it or not. I think the risks are a little bit too high to use radiation therapy post-op, although I will employ indomethacin for 3 weeks, as noted above. What you really need to do, though, is move the elbow. Once the joint has been unlocked, you want to maintain that momentum. And there are certain people like the Mayo Group who advocate strongly for the use of CPM. That has not been shown to be effective on a population level. Doesn't mean it can't be effective for your individual patient. But what we almost always want to do is begin active range of motion within the first 5 to 7 days. And then if you need to, if you're really working on terminal extension or terminal flexion, initiate a course of night splinting to do that. There have been some mouse studies which have shown significant improvement in HO prevention following surgery, but again, nothing in the human population. So one could consider the use of Botox postoperatively, but is not necessary and or considered standard of care at this point in time. So overall, postoperatively, how do patients do? Well, they do quite well. It's not as though everybody with a stiff elbow has immediate recurrence. Most of these patients have durable improvement with approximately 70% improvement, 70% of patients achieving greater than 100-degree arc of motion in this very early Doug Hanel study. Moving forward, meta-analyses and or higher level studies, again, show excellent outcomes following surgical release of both heterotopic bone as well as capsular release. Interestingly enough, when one sees a tremendous amount of HO present, you have an overall complication rate of approximately 22%. Half of that, or 11%, is HO recurrence. The other thing to be very, very mindful of is ulnar nerve injury. And in my mind, this is a very preventable issue. This is a preventable issue because during your approach, one can go immediately and find and protect the nerve. So you really shouldn't be injuring the ulnar nerve as part of a capsular release, as part of an HO resection, unless the nerve is truly encased in bone, which can happen, certainly. But most of the time, I think the ulnar nerve injury is just secondary to the fact that it was not identified and carefully protected prior to your resection and your heterotopic bone removal. In terms of timing, historically, surgeons waited because they wanted the bone to be metabolically stable. They didn't want to intervene in this hyperactive period of time. What we now know, based on an initial study by Jupiter and Ring from the 90s, and then subsequent studies, is that you have equivalent, if not superior outcomes with early intervention. Excising HO in its active phase does not result in marked HO recurrence, which is really a game changer in terms of how one addresses this. So intervening within 6 weeks to 3 months resulted in superior outcomes when compared to waiting 2 years to intervene. And that makes sense. If you have an elbow that doesn't move for 2 years, the likelihood of you having an excellent outcome is quite low versus an elbow that's only been stiff and limited for 3 months. So again, timing-wise, we, at this point in time, in a modern 2024 approach, advocate for early intervention if patients have plateaued with therapy and or there's a tremendous amount of HO which is impinging on their motion. In terms of how long one waits, again, referencing that sort of table where we saw improvement in splinting up to 6 months, I think it's very reasonable, again, in the absence of HO truly blocking motion, to splint for 6 months. But after that, one should really consider surgically intervening. And then the sort of last little bit we'll talk about is the proximal radial ulnar joint, or the PRUJ. If one has a true synostosis of the PRUJ, that's going to be hugely limiting. Their proximal radial ulnar joint will be fused, their pronosupination will be non-existent, and you have to burr this out. This is a challenge. Not only in terms of resection, making sure you don't cause a fracture of the radial neck, but also how to prevent recurrence. And so there's a whole bunch of different ways that one approaches this. The free fat graft has sort of been considered the gold standard in some patients, although you have a complication profile which does show some degree of fat extrusion, and at a very, very small level, when compared head to head, there's potentially only mild benefits to free fat grafting. Anecdotally, again, I like the fat grafting. I've had very good success with that. I think what's important when you do this is to decorticate well, be very, very careful with your dissection, try not to use cautery on periosteum, and then put that graft in there and begin early range of motion. So in summary, you want to prevent the problem before it starts with early range of motion post-op if you can, with indomethacin and or your anti-inflammatory of choice. And then we want to, if we need to treat the problem, we want to treat the problem early, within 6 months. We want to figure out why it's stiff. So imaging, including CT scan, can be of value. And then resect, but don't overly resect. Try to avoid cautery on the bone. And potentially, most importantly, once you've released the contracture, really be careful with the ulnar nerve. Make sure you see it, make sure it's free before you start markedly or sort of aggressively manipulating the elbow. Thank you very much.